Hello, everybody. Welcome to Town Hall. I'm excited to have a panel today focused on Martin Luther King Jr. Day. The national holiday, of course, comes up on Monday. So here at RFU, we're going to talk about MLK and we're going to particularly focus on one particular quote, which I'll get to in a bit. We'll just do a little small talk as people are joining. So to just ensure that everybody gets a chance to join. How many people can see snow falling right now? So I just barely have a little bit of sky. Actually, I have no sky here at the president's office. But Micah, where's your snow?
My snow is 360 degrees around me. Currently in Holland, Michigan, just outside of the lovely city of Grand Rapids, and it is dumping out there quite a bit.
For those of you who don't know, Holland, of course, is on the lake itself. It is the start of lake effect for West Michigan, and they just get hammered. Um, they're prepared for it, but they get hammered. So, let's see here. Dr. Lewis, you are not in snow, I presume. Where are you?
Well, I'm actually right now in New Jersey at Rutgers Robert Wood Johnson Medical School. It is quite cold, but we don't have any snow at the moment.
All right. How about the rest of you? Eric, are you just down the hall from me, or where are you?
Yes, I am. I'm right down the hall, and if I look out my window, I see the exact same thing
The
you do.
same flurries, same sort of pathetic flurries that
Right. It was worse this morning, but it's okay.
yeah, I know. It's at the drive time.
Yeah.
So, and Sion and Abe, where are you guys?
I'm actually back home in Georgia for the moment, and it's clear skies over here.
Yeah,
I'm in Chicago, so same forecast.
same forecast. All right. Well, I think we have a little bit of a plateau, so I'm gonna just get started on some updates from my office. So I'm excited. Yesterday, we announced that Dr. Jan Urban will be our interim executive vice president for research. So Joe DeMario is retiring at the end of the first week of February, and Jan is taking over as our interim as we head into a search. So she is currently the director of the Center for Neurobiology of Stress Resilience and Psychiatric Disorders. She does really interesting and maybe more important, long career since I think 1997 with the university and a really successful researcher and colleague. It's great to have her in this role, particularly important right now. Obviously, the federal situation is all up in the air. For those folks who are, of course, watching the SAMHSA cuts this week, you know, terminations and then reinstatement for programs ranging from mental health care to naloxone on the streets. I mean, just kind of a remarkable bit of chaos around some really important programs. But regardless, having Jan in this role is going to be really important. Next week, I have some meetings with the search firms around our contracts for national search for executive vice president for research. We're trying to bundle it also with our search for institutional advancement, the philanthropy people. This week I also had we had the Unity Week events, which were just a hoot. I didn't get to spend nearly as much time. I understand that the Jamaican food was the highlight at the DNA Cafe. But I had a good time also, painting and wind chimes and international snacks. And then the student band was really good. So that was a great event. And yesterday was the Interprofessional Community Clinic State of the ICC presentation. There are like 468 volunteers from RFU that make that clinic go. It's just astonishing, right? Especially when you think about our size compared to, say, well-known medical colleges and universities down the road or in other parts of the country. This is one of the leading student-run clinics, and just the amount of volunteer commitment that it shows is just astonishing. It is a gem, something that we should all be incredibly proud of. And then I've had a bunch of meetings this week with hospitals, and I just met with Representative Bob Morgan, Mayor Leon Rockingham. I've spent the last 60 days really focused on how RFU works. I'm trying to spend some time now meeting more of our community partners. So uh, many of you may remember that was a large part of my career has been how a university engages with the community, and I have to spend some time getting to know not only folks at RFU but our community partners, because by and large we are, small and scrappy. We will be successful when our partners are successful. So it's been nice to do that kind of work. So I want to welcome this panel. I'm, as always, questions that make town hall more fun. So feel free to put your questions into the Q&A, and we will answer as many of them as we can. You can ask questions anonymously for years, but anonymous questions are, welcome. Feel free to put them in. I want to welcome Micah Foster. He is one of our PA grads. He is the founding partner of Focus Clinics. Evelyn Lewis, who's a CMS grad and president and chair of the Veterans Health Wellness Foundation. Dr. Eric Williams, who's vice president for community. And then Sion Habtamu. I'm getting better. Who is an M2 and SNMA co-president, and Abai Kalu, who also an M2, who president of Black Men in White Coats and co-president of SNMA. So thank you all for joining me today. We're talking about Dr. King, his legacy, what that means. And I asked people, we're going to start with Eric just so people can make sure they get their opportunity to focus. But my first question is really about Dr. King, his legacy, and in particular, this quote. So, of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. He actually said that 1966, March 25th, 1966, in Chicago, at a meeting of the Medical Committee for Human Rights. So he was particularly talking about how federal funding was supporting segregated healthcare. But I think you can broaden it in, obviously his quote is much broader than that. So my question for you all, reflect a little bit on that quote and what that means to either what you've been doing in your career or aspire to, or however that works. So Eric, let's turn it over to you first.
Okay, thank you, Aaron. Yes, for me personally, I think Dr. King, he was one of he was like a precursor to what we call today health equity. Okay, and when you look at that quote and some of the other quotes and addresses that he made, healthcare was on the forefront. Believe it or not, when we think of Dr. King, we don't think of healthcare. We think of course, civil rights, but Dr. King was able to merge the two and to tie the two together. Civil rights, healthcare, quality healthcare, equitable healthcare was a part of civil rights. And you also have to remember Dr. King, is from the South, spent a lot of time in the South and other Southern states, not only Georgia, where he had his church and where he was from, but also when you're going down to Alabama and Mississippi, Tennessee, those places as well. And you're looking at the quality of healthcare. And he believed that healthcare was a fundamental right for people. Equal healthcare was a fundamental right to people. So for me, to being able to tie that together, and that being healthcare being on the forefront of his mind, it helped shape me and believing that healthcare is something equitable and quality healthcare is something that everyone deserves, everyone needs. And when you look at it, when you don't have healthcare, quality healthcare, the nation suffers. Okay, not just the individual, but the nation actually suffers as well. So I do believe Dr. King, he wanted to make sure that people had health care. And I think as a university, one of the things that we can do is make sure that when we are training future healthcare professionals, that we are making sure that they can communicate with all populations, all people that they are going to come in contact with, making sure that they are free of bias as well, and making sure that we are giving everyone that we come in contact with the quality health care that they deserve.
Yeah, so Eric, you got really, really close to that other famous King quote, right? Injustice anywhere is a threat to justice everywhere, right?
Yeah. Mm-hmm.
So, Dr. Lewis, how about you in your career?
Even while Eric was talking, I was thinking about how to start, how to begin this commentary. Um, I spent a lot of time in academic medicine, as well as clinical medicine and research and what have you. And when you mentioned that you wanted to start the conversation with that quote, it made me think about some of the things that I've said all throughout the years of talking about health and healthcare and cultural competency and healthcare disparities and all of those things that come together. And unfortunately, what I, even over the past probably 5 or 10 years, um, some of what I might include in that conversation that I'm having with others is that I've been doing this for a long time. But unfortunately, the slides I used 20 years ago, I can still use today because the numbers haven't changed.
Mm.
And that is the devastating piece about what we're talking about. And so in addition to that, what I bring to that conversation, and I when I say a conversation, I mean it could be a grand rounds, it could be a presentation at a conference or whatever. But I prefer to talk to them, talk about conversations. I take it back like to 1906 or the early 1900s with W.E.B. Du Bois when he talked about you know, essentially the poor health of Negroes. And so if we look at that and we kind of march through time, I will talk about that. I will talk about again in the early 60s, the quote from Martin Luther King. We could also talk about a number of other reports, one, the Heckler report, and then other reports, including the Institute of Medicine, the Schulman report. You know, there's just all of these things, and they're constantly talking about those same issues. And so, what keeps me running as well as what keeps me exhausted is that we talk about these things like reducing disparities, eliminating them, achieving equity, you know, that sort of came about a little bit later. Um, but unfortunately, we haven't done any of those things. And what is even more devastating is where we are right now.
So you and I spoke a little bit earlier in the week, and you've had a real focus on veterans,
Mhm.
in your career. There's a real intersectionality,
Yes.
right, across the Black American experience and veterans, and there's even a whole realm of literature around the relationships between the Bonus Army,
Mhm.
which uprising, which was World War I veterans, just a little bit after Martin Luther King Jr. was born, right, and a whole group of veteran activism and what that meant to the future civil rights movement and things like that. So can you talk a little bit about the intersectionality and how you think about uh, your work with veterans and Dr. King's legacy?
Sure. Again, when you talk about that intersectionality piece, so veterans are part of the general population. In fact, when I'm doing my work with them and talking and at conferences, et cetera, I say they're the perfect cross section,
Mhm.
because within that group we have everyone. You know, any immigrants and different ethnicities and ages and all of those kinds of things are represented among the veteran population. And so they carry any of the things that we're talking about when we're talking about the impact of disparities on the general population. However, when you then look at their experiences in terms of what they do in defense of this country and our rights, you come into all kinds of exposures that become a part of enhancing their issues with health and healthcare. So, I mean, you know, most people are familiar with Vietnam and Agent Orange. And so, again, when I'm having these conversations or teaching or what have you, I say each of our conflicts has its own Agent Orange. You know, Vietnam was there. You know, Gulf One was like depleted uranium. We talk about Iraq and Afghanistan. We talk about the burn pits. So all of those things come together. And if we don't look at this subpopulation that's representative of the bigger picture, and some of those things that they experience, their health outcomes will be 3 to 4 or 5 times worse than others. And so, a huge piece of what I do through the foundation is educating pre-healthcare professionals, medical students, nurses, anybody who could be a part of that healthcare team. Okay, so it's not just med students, nurses, pharmacists, podiatrists, whomever can touch a patient. Educating them, talking with them, having that dialogue, and asking them to do one of the most important things they could do to improve that person's health outcome. And that's ask them if they were ever in the military, if they served. And by asking that question, if the answer is yes, you don't need to be afraid of that because you don't know what to do next, because there's all kinds of guidance and ways of understanding what you do, which is far better than losing that person at age 29 or 20 because you didn't ask that question. You sent them home and said, oh, I don't see anything going on, just take some over the counters. And 3 days later, you're no longer around. So it's those kinds of things that we must understand about that intersection with veteran health and the general population, the health of the general population.
Well, the other piece is, of course, we do not, that service is not equally distributed across the population, right? So African Americans, other minoritized populations are overrepresented in the military.
Yes, and they're overrepresented in the jobs that lead to more of the disparities in the health that we're talking about. Mhm.
Yeah. So, Micah, do you want, the prompt goes to you now.
Oh, well, thank you. Thank you so much. I think that Dr. Williams and Lewis did a phenomenal job. And just to expand on that, I would agree wholeheartedly. When I think about the Dr. King's quote that is often quoted here, I tend to drill down and think more about the advocacy aspect and really challenging these communities and challenging what segregation in medicine look like and calling for direct action. When we think about um, movements and when we think about politics and what happens in Congress and the pressures that we see in academia right now and DEI and think about that in context of Dr. King's legacy, for me, it represents a call for us all to challenge what we see instead of backing down. Prior to prior to the Civil Rights Act and the 60s and this movement, addressing systemic change was, in my opinion, more isolated. Here's an issue, and here's another issue, and here's another issue. And I think what really born out of that is evidenced by reductions in, maternal infant mortality rates, immediately after that in the 60s and 70s was really the emergence of a focus on the social determinants of health that Dr. Lewis alluded to previously. And so that represents a significant, profound contribution from Dr. King laying this groundwork for which we all stand on today. In my practice, we focus on mental health care and the stigmas around that. And I must say that nationally, I feel like we have done an excellent job at reducing stigma in communities as it relates to healthcare, to mental health. And do we have work to do? Absolutely. And should that work continue? Of course. But I do feel like today in 2026, some of the stigma around conditions in African American communities like anxiety and depression and ADHD are certainly less than they were even 15 years ago. And so, we want to make sure that in this work, we celebrate those small wins when we can as we try to move these needles forward, right? The other thing that I really would agree with the previous panelist on is when we're looking at the communities of providers who serve our patients in our various communities. We have literature ad nauseum that shows health outcomes are improved when patients are seen by providers of a similar background who understand culturally kind of what they've went through. And I can think back to 2016 when I was going around the country interviewing at various places to attend PA school. I went to 5 or 6 places, a couple in California and one in Chicago, a couple in Michigan. And I will be honest in saying I stepped on the RFU campus and within 30 seconds, seen the beautiful display of diversity on campus. And this was on summer when many of the colleges were actually gone. And it took about 2.5 minutes to know that this was the university that I wanted to attend, that represented my views and values. And so I was very appreciative of that experience and how it was a springboard in moving forward in this.
That's great. Thank you. Sion?
Thank you, Dr. Sosa. For me personally, as a medical student, the quote resonates deeply. Just a little bit of background. I grew up in Ethiopia. Ethiopia is one of the only countries in the African continent that was never colonized. And I mentioned that to say we might not have experienced racial segregation like the rest of the continent did. But in Ethiopia, inequality looked a little different. It was financial segregation, who got care, who got education, and really a chance at survival heavily depended on who could afford the financial means and people who are not financially capable of. And so Dr. King's work reminds us that justice or even injustice, it's not abstract. It shows up in different spaces. For those of us that are in the healthcare field, or for Vi and I that are aspiring to be physicians, it can show up in hospital rooms and access to care, and even in whether people are treated with dignity when they are the most vulnerable. And for me personally, actually, my background, I started out in poli-sci and international relations with the hope of going off to law school. But I eventually decided or chose to pursue medicine because I believed that healing was one of the most meaningful ways to push back against injustice. Medicine is universal. It's practiced all around the world. And no matter where you are in the world, people need care, dignity, as well as compassion. So I'm so thankful for this opportunity to have this discussion, to bring in a different perspective as a first generation American, African American as well. And so today and in the future, I hope as we reflect on Dr. King's work, we can continue his legacy, whether it's through service, equity, and compassion. Thank you.
Well, thank you. I mean, your thoughts on sort of class and economics are really important, right? So some of it is if you just look at other historical examples, how the English treated the Irish and the Scots. I mean, in the modern world, people wouldn't describe that as race, but they did, right? And I mean, it's how you define things, and it was very much about class. And when you think about the March on Washington, when Dr. King gave his "I Have a Dream" speech, there's a whole it was the March on Washington for civil rights, and people forget that the last bit, the predicate is "and jobs," right? Like it was for civil rights and jobs, because the economics of all of this, healthcare, all these kinds of things, are particularly powerful in all of this kind of conversation. Abai.
Yeah. Thank you so much, President Sosa. I would say what strikes me about this quote is that it doesn't feel like a reflection of the past. It feels like a description of what's currently happening in the present. Even as a medical student today, I see how healthcare is one of those spaces where people are most vulnerable. And I believe when care is inequitable, and we see that oftentimes in mainstream media, those consequences can oftentimes present themselves as things like delayed diagnosis and people living with untreated diseases. For me personally, growing up in a marginalized community, I saw how healthcare inequities, especially in my parents' hometown of Ebro, Nigeria, I saw how difficult it was to navigate a country that has healthcare systems that aren't really set up in your guidance, right? I saw how lack of access to different systems and cultural barriers and that limited trust can also influence how patients' outcomes, even before they step into like an actual clinic setting. And so I believe that Dr. King's legacy has taught me that justice is inseparable from dignity, right? I believe that healthcare is something that should be protected, and dignity should also be protected, right? That legacy is one of the pivotal reasons why I chose medicine. I came from a non-traditional background. I was a chemistry major, decided to go into healthcare
Woo!
consulting, and then I kind of pivoted back and saw that medicine was definitely truly for me because, again, I saw the inequities that a lot of my people were facing, and I felt like I wanted to do more in my power to solve that. And I feel like I carry Dr. King's legacy, especially when I lead different organizations, starting the first ever Black Men and White Coach chapter on this campus, because I saw the need that, okay, it's only 2% of physicians that are Black males in the country. Like, this is crazy. And you see how that number is going down. And I believe as future providers, we really hold that influence and that responsibility that Dr. King constantly challenges us today. It's not just about being that passive participant in this system, but it's truly about being an active advocate for change. And so for me, that means committing to inclusive research, just spreading awareness and being a part of different mentorship opportunities, and really committing to a patient-centered care that is really centered on recognizing every individual deserves an aspect of care that resonates most to them.
So Evelyn and Micah, we heard from both students, both their personal experience and then something about what equity, what that means to them. You both have been involved in practice and things like that. Like, what are the decisions that clinicians make, right? How do you think about those daily decisions that we make that, turn into our contribution to either improving or, the persistence of inequity in health?
That's an excellent question. In reality, the decisions are micro decisions and they're implicit. That is to say, right? They're decisions that happen at lightning speed that we don't actually think about. When you look at modern medicine today, Abai and Sion, you will learn if you're not careful, you'll be put into a factory line, and it's assembly line of patients, and they come in and they go out, and you turn them and turn them, and so we end up relying mostly on heuristics, right? That kind of subconscious, uh, rote routine and rinse, repeat, if you will. And the problem with that is if you're not conscious of those underlying tendencies, they can show up in your practice such that we get these disparities in healthcare that we see today, right? And everybody knows about them. So it really takes active engagement on your part as a clinician to be conscious of them. Now, is that to say that when I'm doing a shift in the urgent care on the weekend and seeing 4 patients an hour on a 12-hour shift that I stop and actively think on every inpatient encounter? No, not really. But what I do have learned to do through these experiences that I have had is when I have an emotional response to anything, to stop and question it, right? And so I might have a patient who comes in and says something off the cuff and that elicits a response in me. And if you don't stop to ask yourself, why did I feel this way? And you just keep moving forward, you unfortunately can provide that patient with substandard care, or, well, let me just get them out of here so I can get on to the next one, right? And so I think one of the most important things that was mentioned by Abai is uh, the need to not be passive, the need to be actively engaged in this process so that when we're thinking in this kind of type 1 medical decision making where it's wash, rinse, repeat, we can have triggers that tell us, okay, wait, there might be some bias there. What's happening? Let me investigate this for 30 seconds real quick and reframe what just happened.
Dr. Lewis.
Yes, I couldn't agree with you more, Micah. I think that piece about active engagement is really key to mitigating those situations. You spoke, I believe it was you who mentioned concordance when seeing patients, and if the ethnic groups and sometimes gender, all of that plays a role in how you can communicate with the patients who are in the same room with you. And those kinds of things become important because typically um, we will listen better or more, or at least the patient feels that you do. Sometimes you're not actually doing that, but the patient actually feels like you do. And if they've got that feeling, then they're going to respond better to whatever that conversation is about and whatever it is they need to do. And so, in thinking about those things, that is what I carry as being a part of being that doctor. Okay. Because if I'm not willing to listen, if all I'm going to do is wash, rinse, and repeat, then I don't need to be there. And the impact of that is very significant. And I think one of the reasons why I focus on it a lot is because I don't always announce that I'm a physician when I go to get seen.
Mhm.
Okay. And so I know what they should be doing much of the time, not always, but much of the time. So I also know when they're not doing what they should be doing, when they're not asking the questions, when they're not engaged, and when they're disinterested and dismissive. And I can't tell you how much I see that. And so, my friends who are other clinicians and what have you, when we're having these kinds of conversations, one of the things we always sort of end up with is what happens with people who don't have people in their families who are physicians or clinicians or a certain level of accomplishment and knowledge and what have you. They don't have someone to come in with them or to ask those questions or to be their advocate in the room, if you will. And so those are the kinds of things that come into play for me, which is why advocacy at this point is such a huge piece of what I do within the veteran population and them getting their health, et cetera, is because the vast majority of people don't have it. They just don't have anyone to do that for them. And so we within that community that you spoke about, Micah, and that you, Dr. Sosa, spoke of, we have to get them engaged and have them understand that everybody has skin in this game. Okay, so if your neighbor needs someone to advocate for them, we need to come together to do that.
So one of the when Micah was talking a little bit about the sort of continual attention, it's really easy for young healthcare providers to find themselves a cog in the machine, right? And that machine starts to make decisions in one way or another that do not reinforce health equity. Like the classic one is, stop taking Medicaid, right? And it can be really easy to find yourself in the middle of that. The great moral document of any institution is its budget. And so who you're hiring and how you're doing that, that's one of the key things, right? That we can ask of each other, right? When we're thinking about what kind of institution we're going to work in or what kind of institution we're going to be, is how do we make sure that we're actually contributing to good in the world in that kind of way. So we have a couple of questions I want to get to, and then I'm gonna turn to our students for a little bit about, and Eric, a little bit about what's happening at RFU in the next few weeks. So from Anonymous, I caught the tail end of the statement that minoritized communities are overrepresented in jobs that eventually lead to disparities. So apologize if my question isn't fully reflective of the nuance. My question is, does this overrepresentation lead to a shielding where these disparities are easy to ignore since they're not obvious? Do you think that's true in other fields outside the veteran community and possibly a contributor to the lack of growth of Black students in medicine? And then this person is also interested in both faculty and student perspective. And I know that it's not just the veteran community, because when we look at COVID and who got sick first, right, it was people in contact with the community, whether they were bus drivers or anybody else. But there's no doubt that many of the jobs that have the largest exposures, potentially harmful exposures, are not evenly distributed across the country. And in a changing climate world, those of us who consistently get to do indoor work, that's even more the case, right? So, but we'll go through. So, Dr. Lewis, this really follows on our little discussion about the inequity and exposures across communities. So, do you think that has an impact on who's going into medicine and how that and yeah, let me just stop there.
I don't know that it necessarily has an impact on who goes into medicine. I think when we talk about who goes into medicine, one of the things that impacts it more heavily, um, typically is around economics and opportunity. Um, I can't help but sort of bring a string into this from what we're now facing in terms of, the elimination of various loans and resources for students to access to pay for medical education. So when those things are limited or taken away, um, a huge impact is going to be on people who look like me, because we don't have, rich uncles and aunts and et cetera, for the most part. Okay, for the most part, it doesn't mean that that's across the board. But for the vast majority of Black and Brown people, that's a problem. And so with, that 2% of Black males and the 6% of Black physicians, period, that line, we've been a flat line like that for years. And so, unfortunately, instead of it easing up, it's going to tilt down even further. And so I don't think that piece there impacts as much, shall I say, as the economic piece, if you will. I recall when I was at CMS as a student and I wanted to do an elective. So I looked through the book that you all had in the office, et cetera, and I found this clerkship in London. And so, you write them and you get permission from the school. Long and short was I got permission to do it. I went over there for 6, 8 weeks. And what was interesting is the students, because there were students from all across the world, it was like the UN making rounds in the morning. We would have conversations and before the attending got there. And we would be talking, and I remember a conversation where they said, "Oh, well, what do you do on this when you're rounding here?" I said, "Well, in surgery, we start, like 5 or so in the morning because we have to come in round on our patients before the attending gets there, so you'll know it, on and on and on." And so they then asked me, "So if you come in at 5 o'clock in the morning, what do you do the rest of the day?" Okay. The other question was, we started talking about, again, economics of paying for school. And they were quite shocked, actually, to know that we had to pay for school as opposed to our country or our government or what have you paying for that, for our education. And so when you look at those pieces there, I think those things impact what our numbers are in terms of going into medicine, far more so than the other uh, piece there that he asked about.
Eric.
Well, as a veteran, and the question actually focuses at least a little piece on veterans, and when you look at the types of jobs that African Americans, I'm gonna just say Black and Brown people in the military have. I was in the Marine Corps first, and then I switched over to the Army Reserves. But we overrepresented in those fields. They get exposure.
Yep.
The infantry. Dr. Lewis had talked about burn pits and Agent Orange back in the day. in Vietnam, but with burn pits and today with folks who went to the Middle East recently, and that exposure is serious, and so we are overrepresented in those types of fields. Now, when I went, I was a little older, and so I transitioned to a more of a logistics position. But back in my early days, especially in the Marine Corps, I was one of those field people. And I had to, and those things were a serious exposure for me if I was deployed during that particular time. But then when you look at the civilian world and how we are black, when you look at black and brown and the lower paying um, positions, ones that may not have health care attached to it. It could be a hourly position, a lower paying hourly position that may not have health benefits there, and how that affects how the treatment that we may get. Okay, and really that when you talk about that treatment, and we talked about that as assembly line of healthcare, and not asking the questions. I have a story about when I was to get some of my services at the VA. And I had a physician. That physician is no longer there, but I had a physician who I had certain concerns. Was asking certain questions. He was a white male physician. And I went to him about certain concerns. He did not answer any of my questions. Okay. I actually had to make a complaint. And I was not afraid to make that complaint either. And I guess some other folks have made complaints, so that position is no longer there. He's my primary care physician there. And so, and I look at others and veterans who actually went over to the VA who may not, what Dr. Lewis talked about, who may not have that spokesperson for them and the treatment that they may get, and not only the VA, but any healthcare facility that they might go to, and you're not having that advocate there for them and some of the treatment that they might have. And so for me, that makes it more important that we get a diversity in the people who are going into healthcare and people who are actually in those hospitals, in those clinics, because they are things, and those folks are more likely to be able to help a person, or maybe more likely to study particular concerns from their population and able to communicate. I think communication is a key, is one of the keys, and the ability to listen to that person and take what they say in and be able to treat that person. And try to get, and I mentioned it before, try to get rid of some of the biases within in healthcare. Okay, especially like pain and that ability to handle pain and things like that. So we want to make sure that we are training our students to be able to listen, to be able to talk that bedside manner there, and being able to listen and take what they're saying seriously. But and I know, Dr. Lewis, you have to probably go on a little bit, but I want to say thank you as a veteran. Thank you for the work you, and I know you're a veteran yourself as well, but thank you for the continued work you do with veterans. And Sian, I know you are, people are looking at that 2LT beside her name. That's because she's a newly minted second lieutenant.
Yeah.
Okay, in the Army, and she'll be providing health care when she graduates and do a residency. She'll be providing health care to military personnel as well. So I want to make sure you two get to talk to one another
We will.
at some point. Okay, so
Yes.
okay.
All right, so there are a couple more questions, and then I promised the opportunity to talk about what we're going to be doing. So, Micah, Sion, and Abe, quickly on this question of sort of leading to African Americans and maybe minoritized populations in general in healthcare. And Micah, you're a PA, so you actually come from a slightly different set of circumstances around these kinds of questions.
Yeah, thanks for asking. So, interestingly enough, I became a PA at the ripe age of 36. My profession out of my youth was finance and business analytics, and went into that world. And then in '08, when the market collapsed, made strategic decision to take it about left. So, just to touch real quickly on that last topic, because there was some great points mentioned there. My very first job after graduating as a PA was actually not in medicine. And I took a job at the Grand Rapids African American Health Institute as their executive director. And the only reason I mention that for Sion and Abai is oftentimes students don't realize that the license they carry opens doors. And one important part of that, sure, is practicing medicine, but the clout and influence and the social and political capital you'll gain with that license can be leveraged to do other things. And so my function at Grahi was to lead and manage a pathways to healthcare careers. And the reason I mention that is that Grant did some wonderful work and has a 20-year longitudinal study going now with it, and et cetera, et cetera. But we looked at diversity in the workforce, and that previous question talked about overrepresentation in those entry-level jobs. And that's exactly what we see is we see plenty of diversity in healthcare, but it's a logarithmic curve in that, right, on those entry positions in the medical assistant world and things of that nature. In the CNA world, there are plenty of diversity, and as we go up the rung, we get less and less diversity. And so we found many important aspects on how to improve that diversity. But just like Dr. King alluded to, when thinking about social determinants of health, one little lever switch is not enough. We really need to support these entry-level positions in a 360-degree manner to where we can have employers encouraging them to move up the rung and paying for education. And you can easily offset that cost in asking somebody to spend a few years with you after they obtain the next certificate and things of that nature, right? So plenty of things that can be done in that area. And I just wanted to say that. The other thing that was mentioned was a hot button that President Sosa mentioned was taking Medicaid. And that was like a knife in my heart because it's a real problem. Me and my business partner, we started the Focus Clinic in ADHD and Learning Center in 2024, partly because the need is so great in West Michigan. Most of our kids are waiting 13 months to get testing done, and they're losing an entire school year because there's just not enough facilities out there. And so we opened up the practice, and the floodgates opened, and the wait list, right, and the patient rooms are filled and things of that nature. But we decided that we would spend an hour intake with the patients instead of 15, 30 minutes. We decided that we would do 4 or 5 hours of testing and an hour to discuss the results. And could we make more money if we made it into a factory? Yes, absolutely we could, right? But we want to provide care where it's needed. The big challenge is thinking about Medicaid and the reimbursement rates, and is it actually possible or not? And we still, and I'm not proud of this, but I want to be transparent. We still to this day don't accept Medicaid at the clinic. And the reason is if we bare minimum, we lose
Yep.
close to $100 per encounter. And
Yep.
we can't pay our staff and keep our doors open. So when we think about Dr. King, thinking about all of these issues within providing equitable access to care, right? It is not just one lever that we're pulling. So we're working with legislation now in the state of Michigan. We're working with a couple of nonprofit organizations to help us to try to fill that gap because these services are desperately needed. I know we're out of time, so I was kind of rushing.
Well, no, so we're gonna switch to RFU here in a second, but I just want to, like, one of the key things, right? Congruency is important. People who are language, culture congruent are incredibly important in the care of people, and there's no doubt that the patients have a different experience. But we cannot have a situation where we're assigning patients based on that, because then that means that physicians and PAs and other people of color have to bear the economic burden of the lack of fair distribution in our society, right? So if economic opportunity is not fairly distributed or equally distributed, then we can't expect that those are the same people who are going to bear the economic burden of care. So it can't be that we're just asking certain people to take on that burden. It has to be all of us who are taking on that burden. So I absolutely understand, Mike, as somebody who has to keep the doors open, right? That it can't be just on one practice or one group of people who have to bear this burden. Now, I do want to switch. Uh, we've got Black History Month coming up. A whole group of events around that. Eric and crew, you guys want to just briefly, because we're coming near the top of the hour. Evelyn, thank you so much. It's so great to see you again. Thanks. I know you have to go teach students, so you know you're off to do great work. So thank you so much.
Thank you all for the opportunity to be a part of this, and I will email you all and see how we can work together to continue this dialogue, but more importantly, the work.
Thank you so much.
Thank you.
Thanks, Dr. Lewis. All right, Dr. Williams. You're muted, buddy.
You think I know how to work this by now, but I'm going to talk about the MLK Day of Service, and then Abai and Sian are going to talk about the Black History Month programming that we have. The MLK Day of Service is this Monday, January the 19th. And I know we're not in school that day. No employees or students will be on campus. But we do want to show a day of service in honor of Dr. King in the Lake County community. Right now, we have three service opportunities available. One of them is at the Roberti House, the Roberti Community House. Okay, we have actually one more slot for that particular house there. And you'll be doing things like preparing food and things like that for the clients of the Roberti House who work with community members, providing meals and other services for residents, especially in of course Lake County, but located in Waukegan, but also the African American museum at the England Manor, which is in Waukegan as well, and helping them. They are a newer museum, and they trying to get displays and things like that up for them. But then we have one service project that's actually here on campus, and that's working with the Safe Place and constructing Valentine's Day cards for victims of domestic violence. And so we're doing that on campus, and it'd be like words of affirmation for those in the construction of those cards. And that'll be on Monday. And we have a sign-up sheet that you should have gotten about 5 minutes before the actual town hall began. And we had a couple of emails to go out earlier this week as well. So please sign up for those. And I'm going to turn it over to Abai and Sion.
Thank you so much, Dr. Williams. We'll be brief. So for Black History Month, every year we have a theme, and this year's theme is Black History through the Eras of Healing, Resistance, and Legacy. And special thanks to also Dr. Williams and the DCCO office, not only for partnering with us, but for sponsoring most of our events for this year's Black History Month. And just a little bit of background on the theme. We felt like this theme frames history as a timeline that we're still living in and not just something that's already finished. We chose healing because for us at SNME specifically, it affirms medicine as both a tool and a responsibility. And resistance recognizes that simply surviving and practicing medicine has been an act of defiance. So this reframes resistance not as anger, but as an ethical courage. And legacy connects past sacrifices to present opportunities and future obligations. So legacy is about inheritance and responsibility, not just celebration. So we chose this theme overall because we felt like it tells a story of how Black communities have cared for themselves, challenged injustice, and built pathways forward, shaping medicine, equity, and hope across generations. I'll pass it over to Abai so he can go over the specific programming that we have coming up for the 3 or 4 weeks we get in February. Thank you.
For sure. Thanks, Sion. So yeah, so we're going to have three marquee events. So first, we're going to kick it off with a gallery exhibit and trivia. And so that's going to be at the Show Gallery. That's going to be Monday, February 2nd at noon. And we're going to send some more information to the school so you all can be involved. And this exhibit is going to be honoring some of the key innovators, healers, and creators who who have contributed to the world that we live in today. And sometimes history doesn't oftentimes recognize these individuals. So we're going to do that here at Show as well. So please come. We're also going to be hosting a Black History Month professionals panel. And this panel this year is going to be in collaboration with Black Men in White Coats. And we're calling it the Shop in the Salon, which was designed to honor spaces that have long served been centers of dialogue and healing for the Black community. So barbershops and salons have always been a place where people can like talk openly, talk about various topics. And through this panel, we're creating a space where students, faculty, and staff, and anyone can honestly hear honest stories from Black professionals in healthcare and how they're navigating that space in medicine and leadership with purpose. And that's going to be Wednesday, February 11th from 5:30 to 7 p.m. in the Centennial Room, but we'll also have a virtual option for those who can't show up in person. And then lastly, we're going to close it off with the Black History Month Showcase. And that's just going to be a place where we're going to feature a keynote speaker and we're going to have vibrant celebrations of Black culture. There's going to be music, special performances, and just moments of healing and resistance and legacy across all generations. So we hope to see you at all, if not one of the events. And we look forward to, again, having a great Black History Month this year. So thank you again, President Sosa, for letting us speak. And we at SNMA and Black Men in White Coats are truly honored.
Yeah, that's great. Thank you so much. So we got a few questions and comments to get to. Pamela Chambers says, you made a great point in mentioning about some who may not yet be familiar with racial differences. I think it's important to stress that to a learning provider that race is a social construct. It is derivative of colonial bias and oppression, and can help learning providers understand structural factors that impact inequity. It is essential to really understand and help these communities. And there certainly is a long history and a huge literature on that across countries and a whole range of examples. And then David Harrison has a question that I think we're going to be able to, well, we've only got a few minutes here. In your opinion, would fixing healthcare in general, for example, stopping the assembly line, help with racial disparities in healthcare? And I think that's a complicated answer. There are some cases where, when you can show systems are following the evidence exquisitely, that care does get better, particularly around maternal mortality. But in other cases, like renal failure, where our calculation of creatinine clearance has been biased, it doesn't work. So it depends on the systemic, injustice that's baked into the system. At least that's my answer. Although I got to say that improving the care that people get in general, helps people who get care. But other thoughts on this? We only got like 30 seconds each, maybe, on this. Micah, you look like you're ready to say something.
Oh, I'm always ready to say something. I agree with you. In 30 seconds or less, it is quite nuanced. Better care is better outcomes for all those involved, right? So yeah, in 30 seconds or less. It will still have some challenges. When we think about economic pressures and factors, right? Just your point about renal failure, kidney replacement, we also see that in insurance actuarial tables, right? And policies and premiums and things of that nature. So training more diverse workforce and providing more cultural competency is one lever that we want to pull that is demonstrated to have positive outcomes, but it can't be in a silo.
You can see it not just across race, but geography, right? Rural communities, you see the same thing. But Abai, Sion, you want a shot at that question?
I think as a Black medical student, what I would add to this conversation would be the point of racial disparities within healthcare keep coming up, and that they're going to continue to come up until we address the number. Currently, we make about 8 to 10% of medical students in the country that are African or African American. And so I feel like the more representation we have in that field, we can see that reflected within our hospitals, within our healthcare system, whether in the seats of policy, and we could potentially have better outcomes. So really supporting minorities and really African and Black and African American medical students reaching those points. That's the only feedback I have as of now.
Right. We are at the top of the hour, so I want to thank Micah, Evelyn, Eric, Sion, and Abe for being with us today. Thank you guys so much. And thanks to all of you for joining us today on the Town Hall. Thank you for all you do to support our faculty, our staff, and our students. It is the work of people like you that make the university such a special place to be. It is Friday. I hope you get to have a weekend. Take care, everybody. Bye-bye.
Thank you, Dr. Sosa.
Thank
Happy
you,
Friday.
Dr. Sosa. Thank you, everyone.